Hi everyone, this is Zach Ford with Age United Sector Transformation Program. It is 3 o'clock on our computer, so we're going to go ahead and get started. Thank you so much for joining us today for the 4th webinar in our monetization series. Today's webinar will help attendees understand key steps in creating a pilot program construct to offer to payers. Today's webinar is going to last approximately 1 hour, and it will include time for questions and answers at the end. You'll notice in the bottom left of your screen, there's a little chat box where you can submit questions to us. So if anything comes up during the presentation, please send us those questions and we will get to those at the end of today's webinar. Today's slides and a recording of the webinar will be available on the Age United website. As a reminder, today's webinar is being recorded and participants are in listen-only mode. You can listen by calling 1-866-740-1260 and using access code 876-2819, or you can enable the audio in ReadyTalk to listen over your computer speakers. And we ask that you please use the chat function to ask us a question. At Age United, our mission is to end the AIDS epidemic in the United States through strategic grant making, capacity building, policy, technical assistance, and formative research. We are a national nonprofit organization with a singular mission and focus to end AIDS in the United States. We lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS, and we've given more than $104 million in direct funding and leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. We also inform the field with best practices and lessons learned, and we advance advocacy based on sound public policy, strategic grant making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. And with all of this work, we work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia, and transphobia, socioeconomic inequality, gender discrimination, and stigma. I wanted to let everyone know that today's webinar, or this entire webinar series, includes free one-on-one coaching with the Menzies Group on a first-come, first-served basis. I believe there are still some coaching hours available, so any community-based organizations that are interested in individual coaching regarding establishing and strengthening relationships with payer organizations should email me at st@ageunited.org. And with that, I will turn things over to the Menzies Group.
Hello, everyone. Thanks for joining us for our 4th webinar. Today, we are going to be talking about creating a pilot program. And so the goal for today's webinar is to understand the key steps in creating a pilot program construct, which you guys can offer payers. And so the outline for today is connecting with payers and discussing pilot approaches with them, using data-driven determination of the initial target population, identifying workforce and technological resources, establishing a pricing construct, and tracking performance and making appropriate modifications to the arrangement. So the first slide, we're really discussing tools to identify payers. So Medicaid and Medicare enrollment levels by health plan are public information. And so this is helpful in discerning which health plans are serving the larger numbers of people living with HIV. And so I've listed 3 tools that we have created, and they're now located on the Age United website. And this PowerPoint will be available on the Age United website, so you can use the hyperlink to get there. So the first tool, Tool C, is a spreadsheet that lists enrollment levels for each MCO in 39 states, and this includes the District of Columbia. So most of these MCOs serve many people living with HIV and represent potential contracting partners for HCBOs. And generally, the overall Medicaid enrollment across different MCOs, like I said before, it serves as a reasonable proxy for the distribution of the Medicaid population living with HIV who are enrolled in these MCOs. Tool D has a similar layout to the Medicaid enrollment tool, but includes Medicare Advantage enrollment from March 2017. Roughly 34% of all Medicare beneficiaries are enrolled in MCOs through the Medicare Advantage program. The MCOs with large Medicare enrollment likely have a sizable number of enrollees living with HIV, and these MCOs should be considered as contracting partners.
Yeah, this is Joel. One other thing to just toss in, as you can see by that we started with Tool C on this slide, is this webinar series sort of is a follow-on to work we did last year, working with 4 specific community-based, HIV community-based organizations. And the toolkit that got prepared for them, I don't know how many letters in the alphabet we got to, but it starts at A and it ends at J or K or something. But those are all on the website. The full report that came from that work is on the website too. But that's why we didn't start at A here. But there are many other resources beyond what will be presented today on the website from that earlier project.
Thank you, Joel. And so the last tool is it lists Blue Cross and Blue Shield companies by state. So if you're seeking to partner with a private health insurance, you'll need to research the key payer entities serving your geographic area. And we've included this tool because Blue Cross and Blue Shield often holds a significant market share among employer groups and individuals who have private insurance. So to save you guys time and effort, this is the research that we've done, and it should hopefully be helpful to you all. And so besides, using our research and doing the research yourselves, we also really recommend using your existing contacts to identify payer entities. So I'll go through in more detail a few of these that we've listed. So for state officials, Medicaid MCO contracts are typically the largest dollar contracts the state engages in. And so staff at the Medicaid agency or legislatures or other state agency employees have strong familiarity with the Medicaid MCOs. And so meeting with these staff and even participating in meetings on the design of the managed care program can be really useful in getting connected with MCOs. Health services contracts. If you're an HCBO who already has some sort of connection to the payer community, even though you're not directly, not directly providing health services, but you're, have some other contracts going on, it would be really useful to just kind of connect with them and see if you could talk to someone else in the at the MCO to get a stronger partnership going, and a partnership that offers more medical services than you're currently offering. In some cases, HCBOs receive donations from one or more area payers, but haven't explored relationships to deliver care coordination programs. So liaising with donor contacts could also provide some insight into contracting relationships. And then also contacting other non-HIV CBOs in the community, so maybe talking to homeless shelters or food pantries or legal services agencies to discern, if they do contract with payers, and if they do, how they actually got into contact with them and how they're currently contracting with them, could help you guys determine who to reach out to. And so these can point to the most appropriate person and also lead to a potential 3-way partnership with multiple CBOs exploring contract opportunities. No.
Well, I was just skipping ahead to the regional medical provider bullet. A lot of the HIV CBOs are getting their clientele by referral from HIV providers, and those HIV providers all have relationships with payers. Their funding stream is the payer community typically, and so getting connected with them about the mix of who their payers are and how many of their patients are aligned with which payers, and what contact people they can open doors to those payers with you is often a real valuable door opener.
Definitely. So once you've actually gotten into contact with an MCO, you're going to want to help them overcome their initial wariness. So MCOs aren't really going to be wanting to sign like large contracts with anyone, and so it's really important to emphasize with the MCO and whoever you're speaking to that the initial contract is, can start off being a small pilot program, which we're discussing today. And this is going to minimize the payer's risk and allow the HCBO to actually demonstrate their value. And if things go well, and as you start tracking your performance, which we'll get into later on, it'll help really show your value. And so describing the potential advantages to partnering with your organization is really helpful. And so we've listed a few key points. So you could help MCOs better address social determinants because you guys are more closely aligned and more closely connected to the community that you guys serve. MCOs also have to, they typically have to submit a proposal in order to become a Medicaid MCO in a state, and so they have to demonstrate their value and their commitment to the community. And so this is where the MCO partnering with an HCBO can really benefit them in showing that they're trying their best to connect with other organizations who can connect well to their members. And then also maintaining health stability for people living with HIV. So the services that many of you guys offer help avert costs and hospitalizations and ED visits. So this is a strong selling point for MCOs to partner with you guys.
Yeah, and in the general philosophy of just trying to get a pilot introduced, it applies in all kinds of areas of the business world, maybe the personal world as well. But a lot of the people we've hired at our firm, we worked with on an hourly basis for a while, and when it worked in both directions, now they're full salaried folks and so forth. But it makes a lot of sense in a lot of business relationships to try to figure out how to get engaged and do some kind of smallish test without taking a big leap and a big risk on either side. And this is can also be advantageous on the HCBO side. If you're getting into something you really don't like, you're not getting in up to your eyeballs if you are able. But on the payer's point of view, we just really think it's a lot easier to sell a smallish pilot than a $800,000 yes or no sort of contract. I think that's much more likely to be a no. And we also think that what you guys do is going to be demonstrably valuable, particularly if it zooms in on the right target population. So that's where this whole pilot model is sort of emanated from. In terms of the content on this next slide, it could be that you're going to need to repackage in some ways. In a lot of situations, I think what you exactly are will fit in some fashion with what the payer needs, but there may be situations where you need to consider aligning in some different way what you do to fit with what the payer's needs are. But the kinds of things a payer needs with its HIV patients who are going, poorly managed and not adhering to medications and so forth are, lining up an initial assessment that might be conducted by you guys rather than by the health plan at the home, or that assessment could occur at the office, but creating a personal relationship, like a lot of you guys do various kinds of case management and so forth, but it's hardly educational in that regard. But getting your hands around and getting a relationship going with the payers, selected target group of people. In some cases, with particularly, we work a lot in the Medicaid arena, and the insults of poverty are not glorious in terms of just being able to get to care, even with transportation often being a covered service. There's all kinds of reasons why care doesn't happen, and for transportational reasons. But one way to break through that is for you guys to literally accompany the person to the visit and back in some situations. Ongoing outreach to support the member. How are you doing? Did this medication change work? How are you feeling? What needs to be different? Did you make it to your meeting last night, or in whatever way you can be either a buddy or almost a clinical case manager or whatever, but be engaged. I think the health plan with its several 100,000 members is not able to zoom in on the target population the way that's optimal typically, and you guys can do that. And as we'll go through this, I think the subset of people that we would pick for the initial pilot would make it financially conducive for you to be engaged regularly. It would be affordable because of what that work achieves in terms of reduction in hospitalizations and clinical crashing. I think all of these things can become affordable when targeted to the right subgroup of the health plan's members. Medication adherence support, that's a huge issue with this condition, obviously. It's changed the whole illness from a death sentence to a chronic condition. But the health plans have, in the pharmacy transactions occur in immediate real time. So if a refill happens, it's in the health plan's computer system immediately. And if it doesn't happen, it's not. But that, unlike other kinds of claims information where the provider maybe waits till the end of the month to submit their claims and the health plan pays it, 20 days later, and there's all this sort of lag information. Pharmacy is not like that. Pharmacy is real time. And so the health plan can create a ping sort of structure if a person with HIV did not get a refill on the indicated date. That can ping to them and ping to you, and you guys can get on the phone with that with that patient and with the prescriber and or the pharmacist and see if a gap in therapy is occurring and get it filled if it is. But this is a condition, in spades where medication adherence is crucial, and so let's all take advantage of the real time things that pharmacy transactions allow to happen, and maximize that, and be aware when Stu has dropped off the wagon or seemingly dropped off the wagon. Let's jump all over that. I mean, that opportunity exists in all kinds of clinical areas now with any kind of refill, but I think it's particularly valuable in this clinical sector.
And staying on the medication side right now, I know a lot of HCBOs also have been engaging a lot with opioid use disorder, and so this is also, this entire webinar series can really be aimed at any high-risk population. So I know we're focusing in on the HIV population, but a lot of this can be taken to opioid use disorder care management that a lot of you guys have been doing. So, even if a large part of even though we're talking about HIV, if you guys are also doing, are in the opioid arena, feel free to reach out to us regarding one-on-one consulting as well. We'd be happy to talk about all the services that you provide and how you can contract regarding that arena.
And there's psychosocial assessments to identify the sort of non-medical needs of the person. I mean, for staying in the Medicaid arena where we mostly work, persons who have HIV it's uncommon for the HIV infection to be their main problem in their life. And so, an HIV infection is obviously not a minor challenge, but it's not number one on their list very often. But in order for them to succeed in managing their HIV condition, they've got to manage their housing and their food and their violence and their addictions and other things effectively, or they have no chance to manage their infection well. And so engaging, again, this is not educational, this is what you guys do, but this is something that the payer needs, focus on HIV. And like Mo said, the techniques that you guys have built for HIV are expandable, exportable to many other non-infected populations. And that, the pilot can start, focus on HIV, and the subset of HIV was the greatest opportunity for a win-win, but there's lots of ways this might broaden to both additional HIV-infected persons and to non-infected persons who have similar track records of, multiple hospitalizations and other issues that are just, the repeat crashing of anyone might be a group that you can serve really effectively. Skipping through the title slide just to the next substantive slide. So in our thinking around this, we're trying to help make a win-win happen out of the gate and give that the highest probability. Not, like I said, not trying to get a huge yes out of a wary payer, but get a small, safer yes for everybody to work within. And who is that initial population? And in our view, it involves members who are particularly high cost in their claims history. They are accessing the wrong things, if you will, that suggest that they are clinically crashing too often. Frequent recent hospitalizations would certainly flag, I think, a great candidate for you guys to engage with in the initial pilot population. People accessing the system in the wrong place, like the emergency department, is a flag that I think you guys can, that's saying I'm not connected to mainstream healthcare. I just got to run, I crash and I run into the ED. That's not what we want to manage a chronic condition effectively. And the health plan is fully able to discern which of its, HIV-infected members have had extra more emergency department visits in the last few months, and you can zoom in on those people. People that just have an absence of primary care. They have not been to an infectious disease physician or a primary care physician. The health plans today typically will have a direct linkage. Everybody has a PCP. They know when and for what reasons and so forth each member has gone to see those providers. If we're pitching a shutout, if persons with HIV are pitching a shutout in accessing care at that level, something's broken. It needs to, a relationship needs to be established and maintained on the front lines of the fight, not at the crisis, point all the time. And so that's something that you guys can do wonders, I think, to plug people in. You're also connected with the HIV frontline providers quite often, quite closely. Sometimes you are the frontline HIV providers. So there's a lot of opportunity to just use your acumen to get people engaged in the front end care. And a lot of times, if you can successfully get that relationship established and maintained, then 2 months later you might not need to do a whole lot if that's working as it should. And that provider can take on a lot of the frontline things, although there are lots of limitations on how far they're going to be able to go to assess and help with the housing and social determinants type things that you guys need to be involved in. So I'm not suggesting that you dial yourself out with these people, but we definitely need to dial in the frontline care where that doesn't exist. And people who aren't getting that and who do have high costs make perfect candidates for this initial target population. People not getting the medication, not even accessing the medication, who are infected with HIV. This is a death sentence if you're not on the regimen. It's a death sentence again if you're not adhering to the regimen. But it's certainly clinically, even without throwing the word death around, it's just not clinically anything close to clinically optimal for people to be not on HAART, on highly active antiretroviral therapy. And so, like I was saying before, given the real-time nature of these transactions in pharmacy, we can identify the people who are not accessing it. And the worst combination is someone who's not getting primary care, not getting HAART, but is hospitalized a lot, is going to the ED. Those people are crying out with their claims that the tape they're playing, their lives are broken in the 364 days that they're not using the healthcare system. They need something different from you guys, and those are very unfortunate cases, but those are perfect cases for this pilot, for where you can plug in and create a financial and a clinical win-win for everybody. Skipping ahead to the workforce aspects, as we were just describing earlier, these partnerships may create a different kind of staffing need for you guys. And if you have a $150,000 contract with XYZ Health Plan, it may be to do things that you already do with the cadre of people you already have, but it may be a situation where you do need to hire a part-time driver or a full-time housing case manager, whatever, depending on what the composition of the pilot population is and what the gaps are between what you're agreeing to do and what you can already do with the team you have. And and a lot of times this pilot population is going to be just plain additive workload-wise to what you're already doing, and your people already have a fully consuming day job. So you just may, from a bandwidth point of view, need to hire up to staff this contract appropriately. But we just bulleted out the different kinds of positions that might come into need to fill to accommodate the contract. Even the smallest pilot contract can be quite a bit of work. For a person, we're talking about high need cases that need a lot of work per person per month. So it could change your staffing.
Yeah, and even, we've listed administrative assistant. So when you guys, hopefully do start partnering with these large MCOs and have to start submitting claims data, for reimbursable services, that's a whole new arena that many, or at least some people haven't yet explored or have experience in. So that's definitely something to take into consideration when going into these contracts.
And there's other publicly available data resources that can be useful in just getting your ducks lined up for these contract opportunities or to perform within them. But probably most of you guys are fully HIPAA trained and conversant in how what you can and can't do with personal health information and so forth. But there are publicly available training programs and certificates and so forth that you can put on your wall, passing a course in this if need be to, and the health plan may need to see evidence of that for the people that will be interacting on such a personal, profound level with their high need members. And so there may be certifications that you probably are already there, but there may be things that you need to do just to get through those sorts of requirements. And I don't think that'll be a heavy lift for you guys, but it may come into play at times. Particularly, and certainly if you have new hires coming in to support the contract, they might need to at least at minimum go through this sort of process. One challenge that occurs when you're contracting with payers. You've got to bill them, and if it's something like a monthly case management fee per person, that's a much easier invoice than if it's a per unit sort of thing. But billing can become a pretty significant new, foreign new challenge for entities who've been 100% grant funded. So that's something you'll have to consider if that needs to happen, how to accommodate that. And then there's a data, we're getting more and more data driven in every way, but certainly this kind of contract is much better, much more successfully entered into and managed with good data than without. And the data systems that the HCBOs have generally are not equipped to monitor clinical care and capture all these touches. Some certainly are. I'm not trying to be derogatory, but the health plan's IT systems typically are super strong at this. So there may be some way that you guys can plug into their system and not need to purchase things, but there may need to be some kind of IT purchasing to accommodate the data-driven needs of these contracts.
And also looking ahead, while you are getting into these contracts and are proving yourself, it's good to have the data backing that up. So when you guys do finish the contract and want to continue it, or you want to reach out to another payer, multiple payers, this is something that you could have in your library, so it's more easy to show, to show your value, which you hadn't probably had before.
We have a slide later on that kind of walks through what the pieces are of what kind of data we think need to be tracked, which might help you think through whether your existing IT can handle it or what add-ons need to occur. So we'll get to that in a few minutes.
And so we discussed this on the last webinar. So for those of you who were on the last webinar, I'm just going to briefly go over this one tool again. So this is a worksheet that I developed to help assist HCBOs in establishing initial prices for their contracting partnerships, and also to assess the performance within these contracts. So the first tab lists different staffing positions and the monetary values associated with each. And everything in yellow, it's up to you to change how it best fits your organization. We listed potential positions that we thought that you guys might have within your organization, but as we previously discussed a few slides back, this is going to change depending on your contract and what services that you're offering the MCO. And so this worksheet is also listed on the AIDS United website.
The Excel file, just to speak a little more to that. So the slide that okay, you can pull it up.
Yeah, and I can pull it up really quickly. Yeah, and so this first slide, like I mentioned before, it's just it lays out everyone's salary, the benefits loading factor, the organizational overhead loading factor, and it's just a good way to really keep organized with who, just financially keep organized. And then this monthly services tab, we've listed initial assessment and then ongoing case management. And these can all change again based on what you're providing the MCO. But it's a good way to track how many hours your staff is putting into the contract, and just making sure that you guys are staying within the constraints of the billing rates that were agreed upon between you and the MCO.
And if you did need to, if you are going to be paid on a monthly fee basis per person for the care coordination or for the services you'll be provided, that first tab derives what we think an hourly rate would be, and then this tab derives just what the monthly hours of effort would be, and those two things together, you probably walk through that, Mo. But this construct allows you to estimate all that at the front end, so you can at least credibly put a price to this. You may not know until you're really in play how many hours per person it's going to take on average per case, but you can, I think with this spreadsheet, make a better run at what a fair price for both parties is than if you do it without something like this. This doesn't nail to the wall what the exact price, ought to be, but it gives you a tool to get yourself towards that, and then work, like Mo was saying, modify it after the fact with real data, and then you can adjust your existing price appropriately, and you can price the next gig more appropriately.
And then we've also listed initial assessment and individual care plan workflows. And this could be changed based on what you guys are doing for the members that you're going to be serving. So if there's going to be an in-person assessment, a telephonic assessment, just really putting the activities that you're going to be providing and laying them out and laying out a construct to kind of note and just get yourself organized as to exactly, kind of based on what Joel was saying. Play with it the first few times and then really start gauging how much each effort actually costs, how much time is going into it, and then establishing a more set-in-stone agreement between you and the MCO. And this the last tab really just creates a large summary on all of the subsequent tabs. So you have the one-time assessment fee, monthly case management, and then it wraps it all up into 12 months of case management per enrollee. And then we have one that includes the profit margin and one without a profit margin.
Yeah, and the different enrollment levels just give a sense of what the annual revenue would be at these prices, at these different enrollment thresholds. So it's just sort of to give you a sense of what it brings in the door to operate these services at different scales of pilot enrollment.
And I know I keep bringing back the one-on-one consulting, but if you guys see this as valuable and would like us to walk through it with your staffing plan, your financial structure, we'd be more than happy to do that.
Our last slide, I'm sorry, I'll set up the spreadsheet now. Our last slide just gets into, ongoing monitoring of data-driven monitoring of the contract and relationship. But we think if you've got 83 people as you're care coordinating for a health plan under a pilot contract, I think it makes sense to have a standardized information flow that comes to you from the health plan in terms of what's going on with those people. What in the past month, what touch points did they have with the healthcare system, what medications did they fill, et cetera, and then you would add to that data set what you've done, what your touch points were, what you've learned, and so forth, and that would get shared back with them. But identifying, with things like medications, I'd love to see that occur in real time rather than a monthly report that Stu didn't refill, his HIV med seemingly on time. But on a monthly basis, you can see that this person had an ED visit or had 2 ED visits. That changes what you would do versus not having that information. In some cases, some of these plans, by the way, some of these individuals, by the way, are just going to be lost. One challenge health plans have serving high need and particularly high need impoverished subgroups is the transients and the unstable addresses and the changing cell phones and so forth make it just hard to stay in contact, and that's another area that you guys can help with. But But the health system touch points do typically generate data, and that needs to find its way to you guys systematically, not just haphazardly, in order for you to fulfill an optimal role and figuring out where to put your horsepower and how to best help each individual. I think a lot of this data will hopefully show that with your guys' involvement, people are going to become more stable and less costly, but that should all be part of what's in these monthly reports. And then as you go forward, hopefully showing, I think another type of thing to do with the data is compare with your guys, 6-month picture of claims costs for each enrollee, and roll up the 83 enrollees who are in the pilot, compare that to the 6 months before you were engaged, and let's see if we can quantify the impact and the savings that your model is hopefully creating. And if it's if you're creating a 35% reduction in total cost for these people, and the number of hospitalizations has gone down, and we can just sitting there vividly. Now we've got an enormous argument to expand this from 83 people to 183 people. And then at some point, the return on investment might not be there any further. Maybe it's at the 400th person or something where they're so healthy and the amount of work you're doing is so intense that it isn't paying off further beyond that threshold. But let's walk yourself up with evidence of accomplishment. So that's the kind of partnership we're envisioning. Is a pretty easy yes for the payer initially, and then there's an even easier yes if you're in the situation I described where you've saved them dozens of percentage points on net, even after what they've paid you. Then it's pretty easy for them to broaden it. And like we said earlier, it may be very appropriate to broaden this outside of the HIV patient population to other people with similar patterns of healthcare usage and cost, just with a different illness or set of illnesses. So that's the type of pilot we envision is achievable and will get you in the door and allow you to build a large long-term relationship by proving your value from inside the tent rather than selling it from outside the tent.
And Joel, just to go back, full circle to where we started and what Joel's current and most recent sentiments were with proving that you were successful. I think it's also, the point that Joel made earlier, very important to make sure that these workflows and cost savings modeling that that hopefully these tools will help you achieve, it is shared. That is how you can get a pilot to be even established. So even though you want to make sure that you're using the data at the end to evaluate how successful you were and where in the process, in the workflows, anything could be improved upon, making sure that you have that information at your ready to when you're engaging with payers is super important. I recently have witnessed, engagements with not necessarily HIV CBOs, but other organizations, other community-based organizations where a health plan couldn't proceed because the organization was not able to clearly articulate what that workflow would look like, what the impact would be towards a member, and what the potential cost savings could be. And so making sure that you take that time to draw out as much as you can. And, it's obviously a template. It's obviously a model. It's not set in stone, but these are based on assumptions. And this is the ideal state of where your shared patient member should be going in terms of how they touch the healthcare system.
Thanks, Purnima. So that's it for us, and so we welcome any questions that you all might have.
Hey everyone, it's Age United again. So we are entering the question and answer portion of today's webinar. In the bottom left corner of your screen, you will see that there is a little chat box. So for anyone that has questions for the folks at Menzies on today's presentation, please use the chat function to send us those questions, and we will read those out to the Menzies group so that they can respond. So while we're waiting for some questions to come in, we will let folks know that there are 2 additional webinars in the monetization series. Our next webinar is going to be on November 15th, and it is going to focus on collaborative learning. And on December 6th, we are going to wrap up with a webinar on putting the pieces together. Does anyone from the Menzies group want to elaborate at all about what folks can expect on those 2 webinars?
Menzies, I think you might be on mute.
Yeah, we're off mute, sorry.
So,
oh yeah, go ahead, Mo. I saw that question came in. I'll let you read and respond.
So Denise is asking if this could be used with grassroots organizations that have not received their 501c3 yet.
Yeah, the construct we're describing doesn't have any legal entity barrier. I mean, a payer could contract with any company to do this type of partnership. So we don't think that the absence of a 501c3 matters in terms of is a barrier to this, to a payer saying yes or no to this, or to legally operating this kind of our company could do this kind of contract with a payer if we could get them to say yes, and if we had the right skill set, which we don't do what you guys do, but I think you're okay from a legal structure point of view, almost no matter what your legal structure is.
And then Carter is asking, does the payer refer members to our HCBO, or do we advertise our services and hope people utilize the services, or both? So I think this just depends on the contract that you agree upon with the MCO or whatever payers that you're contracting with. Joel, do you have any?
Yeah, I think, so let's stick with the 83-person pilot that I've randomly tossed around in prior comments. Those 83 people, in my view, would get some kind of notification from their health plan that they've contracted with AIDS United, the AIDS United CBO of Chicago, and that they'll be in contact with you. That you cannot force these members to engage with any given party. They have utter free will in this, but typically it would work in that kind of direction where you'd identify a certain target population, and maybe the contract would start with 96 people, 13 of whom you either couldn't locate or chose not to engage with you, and you would then the pilot would then only occur on the 83 who you did successfully contact and who agreed to work with you as their care coordinator, partner. So it's typically going to come that way rather than through advertisement within a health plan relationship. They're identifying, you've worked with them and with their data to identify which people make sense, and then once you agree with the health plan about these 96 people, you'd get the contact information, but they would make the initial contact to get, I think it would be awkward / inappropriate for you to just blast in uninvited, without the health plan, sort of having blessed this. And then, so the initial contact would typically be from the health plan to all of their members who you'll be helping them with or trying to help with, and then you would make your reach out.
And thank you for the question.
So we've got about 10 minutes left on today's webinar. So if there are any additional questions, please let us know. There's currently none in the queue, so we will give just a few more minutes to see if folks have any additional questions. And while we wait for some more questions to come in, I just want to highlight once again that if you're an HIV-focused, community-based organization and you are interested in receiving some one-on-one technical assistance from the Minges group, you can give me, Zach Ford, an email at st@ageunited.org, and I will be able to put you in contact with the folks at the Minges group to set up introductory meetings. Hi, so someone is asking if the tools from the slide would be available online, and I'll just let folks know that if you go to Age United's website under resources and go to the monetization webinar series page, that all of the toolkits that the Minges group developed for Age United are available there. There's a really in-depth report that they also wrote on monetization that you can review. All previous webinars are available to watch, and all webinar slide decks are available to download. So all of those resources are available on Age United's website.
And you will receive an email either at the end of today or early tomorrow when this recording and slide deck is online with a link to the page where you'll be able to find all of these resources.
All right, folks, so we're about 5 till, and we do not have any additional questions in the queue. So we're going to go ahead and wrap up today. Thank you so much to Joel and Mo and Purnima from the Minges group for putting together today's presentation and sharing your expertise with us. The next webinar is going to be on November 15th, I believe. Yes, November 15th. You can sign up on Age United's website, and we'll be sending out emails about it. Individual coaching requests can be sent to me at st@ageunited.org, and the slides and recording from today's webinar will be available online and also sent to your email. Thank you so much for joining us, and we hope to see you in a month.
Thank you, everyone.
Thank you. Please stand by.